Not getting your health and wellness questions answered at your doctor's office? Are you ready to take control of your health and well-being? Do you want the proper tools to set you on your wellness journey? Do you want to meet and chat with expert members of the healthcare team? Well, step into Realtime with Dr. Stacy. Hi, I'm Dr. Stacy DeGale, your personal physiotherapist and wellness consultant who wants to make sure that you live your best life. We'll be chatting with wellness team members and inviting you as you are the center of that team. And we'll be doing all of this while you are in the comfort of your own home or office. Join me in Real Time with Dr. Stacy as we discuss everything health and everything wellness. Good afternoon, everyone, and Happy New Year. It's such a joy to be with you again, and we're starting off Real Time with Dr. Stacy in a fiery fashion with my upcoming guest. So before I introduce her, because we have no time to waste, so many of you said you were going to log in, I just want to remind you as to why we have this show. This is an opportunity for us to talk to our local experts. Sometimes we live in this world where we think that in our sweet Trinidad and Tobago that we do not have experts here in certain fields. And let me tell you, some of the best trained medical practitioners and health and wellness consultants all come from Trinidad and Tobago and the rest of the Caribbean. So thank you for joining, and please feel free to share this live with your friends and family, because this is a very important area and often not spoken about area that we're going to delve in with today. So I know you're tired of seeing me and hearing me already, and you're not here to hear me. We are here to invite our first guest for 2025, and that is our dear and beautiful Dr. Nadya Watson. Welcome, Dr. Watson, to Real Time with Dr. Stacy. Thank you for saying yes to being our guest today.
Thanks for having me. I can't wait. I'm very excited to do this show with you.
Thank you so much. Listen, guys, when I asked, and as boldface, I didn't even send a proper email. I sent a WhatsApp message. And literally within seconds, she said yes. So, this shows the enthusiasm and the love and passion that Dr. Watson has for her field. So let me tell you a bit more before we dive in. Dr. Watson is a physician who was trained right here at the University of the West Indies, who has her MBBS as well as her master's in palliative care medicine. And let me say, she graduated with distinction just a few years ago, 2014. She looking good, eh? She operates the Healthy Living Medical Practice in Vista Bella and specializes in family medicine and palliative care. With 17 years of experience, she has built a strong reputation for exceptional patient care. And I am privy to that because I have the pleasure of sometimes treating some of her patients, and there's nothing but praises that they sing for her. And Dr. Watson also actively shares medical and social insights on social media. So you might recognize her when her favorite and famous phrase, top tip. So if you don't, we will share with you her social media handles so that you can get the top tips from Dr. Watson about your health and wellness. I mean, extremely popular, but more important, extremely useful information with her top tips. And she makes sure that she stays current with medical trends to enhance her practice and the care that she lends to her patients. So Dr. Watson, again, thank you so much for being here. And we have a few people online already. So guys, remember, during this show, feel free if you have any questions, feel free to type them in. We're going to get to you. We're going to get to all your questions. And if we cannot answer, you know that I always follow up with you offline. All right. So let's just give Dr. Watson an opportunity before we go into how she got into this area. I want us to have a better understanding of what palliative care really means, because sometimes we hear the word and people instantly think doom and gloom. So share with us.
Okay, so palliative care is supposed to be a multidisciplinary type of care where you have a bunch of doctors, nurses, oncologists, everybody working together to ensure that each patient has the best quality of care. But in Trinidad, it's a very, very new form of medicine. We are very rare doctors. We have about 5 or 6 of us in Trinidad and Tobago. I cover mostly central and deep south. Sometimes I cover further. I have patients even in Port of Spain now. And what I really do to make it easy for people to understand without thinking that I am doom and gloom, think of me as someone that can come in and fix things that give you extreme discomfort. So, one of the biggest things I do is pain management. I also place caregivers, I sit with caregivers, I reassure them, I try to guide them as how to take care of patients, especially when they're bedbound. We talk about diet, we talk about constipation, we talk about dry mouth, we talk about advanced care directives, because a lot of people that are diagnosed with terminal illnesses sometimes think that when doctors tell them you're going to have chemotherapy and then they tell you, oh, you're in remission, people think they're cured for life.
Mhm.
Understanding what the word remission means. The word remission means that within 5 years, this cancer can come back, and if
Right.
it comes back, it's fast and furious. And I don't just deal with cancer patients. I also deal with any terminal type of illness, so heart failure, COPD, renal failure, all these different types of patients. And I try to give you the best quality of life, meaning I try to give you no pain, the most comfort, the most dignity when it comes down to the end of life. I can be contacted, like I have patients that come and see me when they're diagnosed with different, let's say cancer. I have a patient right now who came to me because she was diagnosed with colon cancer and she wanted to know what I thought about the steps that the doctors were taking,
Yes.
because she looked at my top tips and she said, and she looked at me. I do a thing with on Synergy Breaking Dawn with Stefan Reese, and she was looking at me and she said, "There's the doctor that I need to go and talk to." And we're going through the journey together. She just had her surgery. She's about to start her chemotherapy, and I'm there with her every step of the way, guiding her. And I guide patients because sometimes they may feel that they are curative,
Yes.
and I'm there to tell them that even though you're in remission or even though you feel better, anything could happen to you at any time, including you and me, Stacy. We could get hit by a bus, etc. So it's not a bad
Yes.
idea to have an advanced care plan or end of life care plan, so that if something happens to you, that we know exactly what we are going to do next. Nobody's going to second guess or ask, oh God, what mommy have
Yes.
to do? Did she want burial? Did she want funeral? Does she want to have to be put up on a ventilator? Does she
Yes.
want compressions? Does she want this? Does she want that? No, we all know what's going on. We have all of these things written down. The family is in agreement, and we move forward, and that makes life a whole
Whole
lot
lot
easier.
easier. So
Yeah.
you
So that's
you've touched on so much already, because you're looking at it's so, I have to commend you for from the start stating that palliative care is a team effort. And yes, you are that specialist to drive home certain things, but there's a team involved, and that team involves a wide assortment of healthcare professionals, the patient, and their family.
yes.
So yeah, so that is very important, because quite often many persons believe in this sort of thing, that they have to see one person. But persons that, such as yourself, would assist in coordinating and making things much smoother and easier for the patient and family during this time, and also to bring some level of understanding as to what is happening. Because everybody going, and I mentioned this to my viewers already, everybody like to go on Dr. Google,
Yes.
and
Yes.
we're not advocating Dr. Google, guys. All right. But can you somebody just asked in one of my platforms here on my phone, I'm seeing they're asking about the difference between palliative care and
Mhm.
hospice care.
Okay, so palliative care, I get called in. That's if in a multidisciplinary team. Sometimes I have oncologists that call me from the very get go, from the from the time that the patient is diagnosed, and that could be from stage one. It
Right.
doesn't have to be end of life. So I'm doing the entire journey with these patients from the onset of diagnosis straight on. Now, palliative care is all that I discussed in terms of, because even if you're going through chemotherapy, etc., sometimes you have pain, you have discomfort, you have nausea, you have vomiting. You have to be at home with caregivers, and the caregivers need to know how to take care of you. So I do all of that. But hospice is when I tell you that you have weeks to months of life. So that's very different. That means that you probably went through remission or didn't have a chance to even go into remission because this cancer or whatever illness was identified very
Late.
late on, and they've done a lot of different treatments, but the cancer or whatever it may be is still advancing, and you're not winning that battle anymore. And we give you weeks to months of life. It's an estimation, but
Yes.
because of my experience, I'm usually correct. So that's the difference between full palliative care and hospice, because hospice is when we just take care of you and make sure that you are absolutely comfortable because we actually know that death is near.
Yes. And so guys, remember, palliative care is that journey from as early as diagnosis
Mhm.
with condition, as opposed to hospice care, which is confined to those weeks to months prior to us passing, which, we speak about, and we need to be more open and less taboo about speaking about death. And because that is a journey all of us will walk at some point in time. So thank you for that distinction. Now,
No
what
problem at
are
all.
some of the misconceptions, though, of the common misconceptions about palliative care?
I mean, even with doctors now, even though they are oncology trained and all of that, sometimes when I say, okay, well, this sounds like a person that you should send to me, and they'll go, no, 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 they're not ready for palliative care yet. So I'll be like, what you mean they're not ready for palliative care? Everybody, once they diagnosed with any terminal illness, should be ready for palliative care. Did I touch something, or is this how
No,
I
no,
spoke?
no. I just
All right,
zoomed on you.
all right. I say so. Palliative care is like, say a patient is now in fourth stage, so they now realize that the cancer is spread, but they actively doing chemo, radiation, etc. When you say, I think this patient needs palliative care, understand that I do the background work. While you trying to fight the cancer and doing the chemo and the radiation with the patient, that's wonderful. But you are not looking at what happens when the patient goes home. When the patient is home and you have two caregivers, which is two family members, these two family members are working, they're frustrated, they don't know what they're doing, they're lost, they don't know how to help ease the
Yes.
pain, because yes, they're given pain meds, but they sent home. Nobody's following up to say,
No.
hey, how that morphine going, boy? The 2.5 mils, which is less than nothing. How that working, boy? It working fair. Most of the time, the family members say, Jesus, this pain medicine not working. The
Hmm.
patient constipated, because little do a lot of people go forward to tell them that when you are on an opioid such as morphine, the one thing you cannot get away with is constipation.
Mm-hmm.
So I have to now adjust meds in the background, tell caregivers how to change diet, how to feed the patient
Yes.
at this stage in life, how to manage, even by offering them nurse aides or nurses to help them. Even following up 48 hours, every 48 hours to see if I need to adjust the meds, putting them on medication for the constipation,
Yes.
and also doing simple things like mouth care, because when you start taking all these medications, your mouth gets very dry. And also note, when your body fighting, when it fighting and they're trying to fight a cancer that beating them, you know what happens? You start to lose a set of weight and you
Mm-hmm.
lose appetite. And then caregivers don't know what they're doing. They go, oh God, she not eating, she not drinking, what to do, and buffing the patient up. When
Hmm.
I have to come in and tell them that's normal. It's normal for patients to be like this when they're going through these steps. So when people tell me, nah, 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 they need palliative care, it's because they don't understand what happens when the patient leaves that hospital and enters their home.
Mm-hmm.
When recently I went to the home of a physician, and I can't do all the la 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 into that because it's private.
Yes.
But we took away so much worry
Hmm.
and confusion and frustration that the family was going through because they did not know what to do. And
Yes.
I guided them bit by bit until the patient passed. And they were like so grateful because the patient was able to pass with dignity, pain free, because we made sure that that we came there to do it, and we did the job.
Job.
Yeah,
So
so that's
it
what we do.
extends so much into, and this is why it's called palliative care. It's that
Yeah.
caring part, I think, is such an active word to describe what you do, because it goes beyond just prescribing medication. Anybody could do that who has a degree. People who don't have degrees, everybody. I remember when my father was alive, because he would get knee pain, man, he was prescribing nutmeg oil and camphor, and he used to make a mix. Right? So he was his own doctor and prescribing to, and listen, people used to line up
Mm.
for
Yeah.
nutmeg oil and camphor to rub on the joints, and your daughter is a physiotherapist. But let him rest in peace. But that care and that knowledge that you have allows you to give appropriate advice for that person during varying stages of their treatment and or journey. And this is what I really want our viewers to remember, that everybody has a place, but there are certain people who are designed and are trained to fulfill certain things. And persons like Dr. Watson are trained to give you the advice that is appropriate so that your patient or family member can have an improved quality of life for as long as is possible.
Yes.
And you know, something you mentioned with the morphine, and I want to go into a little bit more because I know you really wanted to speak in a bit more detail about the pain management part of palliative care. And somebody just sent me a WhatsApp and say, "What about weed?" So the herb, I don't know if we can say weed on live television, but the herb. So just tell us a bit more about palliative care and addressing pain management and how it's different from standard medical care.
Okay, so part of our training is understanding where the person lies on the pain scale. It's as simple as that to me. I have a 0 to 10 pain scale, and I try to ask patients. So some of these patients, they're so weak, they can't even really speak. So I have a little chart with faces on it, with a happy face and a very sad face. And I say, out of 10, where do you think your pain level is? And most of them might point at the 10 out of 10. Now, the family member will tell me they're not in any pain. But usually, Stacy, what happens is a lot of patients will lie in bed stiff. Like, if I just leave you stiff on bed and I'm not moving you, you will have no pain.
Yes.
But from the minute I say, okay, well, let's turn over the patient to make sure there's no bed sores, etc., and the patient starts to bawl, I say, so what you call that? That is pain.
That
All
is
right.
pain.
When we ask the patient, how bad is this pain when we turn you? They go, well, only when you turn me, the pain is like 10 out of 10. So therefore, I can't bathe that patient, move that patient, change the patient's diaper, because most of the time on bed bound patients, you are wearing these, what is called diapers. And if I can't do any of that without you screaming, then you are in pain. So
Yes.
we have a scale. There's mild, moderate, and severe pain. Most patients that we go to are on pain meds that have 10 out of 10 pain. They're on pain meds from mild to moderate pain, and that's what they sent home with. Things like Tramadol and Olfen and Panadol. In fact, a lot of them on Panadol, and I'd be like, you know what? I want to give whoever give you that. I want them to be birthing that child, and in the middle of birthing that child, I gonna give you 2 Panadol and say, take that. That will fix that pain. You understand? That's wickedness to me.
Wickedness.
So what we have to do is we then have to start introducing morphine. Now that in itself is a big hoo-ha, because from the time they hear the word morphine, everybody hands go up in the air.
Yes.
And that is kill you, and that's where it starts. take at the end of life, and that's something that you could get addicted to.
Yes.
But then we have to start talking about the myths of morphine.
Yes.
Open any book on pain management, no matter where it has been written, from University of Toronto, wherever, and see what is the gold standard for severe pain. It doesn't matter if the severe pain is because you break your ankle, you fracture your knee. It doesn't. Stacey, I'm sure you've seen, you were there when we were rushed in and a patient was trying to do physio, and their bone snapped.
It was right. I was right there. I was
Yes.
there. Yeah.
What would you give her, two Panadol?
Thank
Give
you.
her two Panadol and say, here, darling, because that's what we're giving you. No,
Mhm.
severe pain is the gold standard, is
Yes.
morphine. And in Trinidad and Tobago, we do have morphine. We don't have all the other fancy drugs that abroad will have, like fentanyl patches and
Right.
pops and all these things. But we do have morphine. Now, let me tell you something. Sometimes we have a real shortage of morphine, and that's
Yes.
really, really irritate me, because it's the one thing that we have to give all these suffering people.
Right.
But
To get
once you are
control.
10 out of 10, Stacey, the mode is morphine.
Yes.
And let me tell you the other beautiful thing about morphine. Morphine not only helps with severe pain, meaning I give that to patients. After I give them, 2 seconds later, they hand behind their head, they fold in their leg, they talk into
Yes.
the family, the same family that say they have no pain,
No
right?
pain.
The same patient that say they only have pain if they turn. You can't live like that. That is not a
Right.
quality of life.
Correct.
So when you are pain free, you're able to do things, you're able to walk around. I have professionals that have
Right.
stage 4 cancers that work and they're on morphine and they're able to do everything normally and pain free.
Right.
Some of them are not at that stage where they can be active, but I do have active people on morphine that have severe pain from terminal, from stage 4 cancer.
Right.
So how you give morphine. You cannot just slam a big bottle of morphine and say,
Mhm.
here, boy, here, just drink this thing. No, you have to start at very small
So,
doses, especially if we call opioid naive. That means you've never taken an opioid in your life.
right.
Start at a very, very small dose. And over time, let's say after 24 to 48 hours, we contact the family. We say, let's hear how it's been going.
Yes.
If they're not happy, we increase the dose and we keep increasing the doses until we are happy. Initially, for anybody, do not be afraid if you see sleep, the patient sleepy, because that's the
Yeah.
next thing. But mommy sleepy. Oh, you want mommy to be bawling in pain or
The
sleeping
pain. Or
and being
sleeping. Correct.
crushed?
With some comfort. Correct.
Yes, the sleepiness only lasts for about a week,
Right.
including nausea and vomiting. Nausea and vomiting only happens for the first week to 2 weeks, and then we don't even have to use medications for nausea and vomiting.
Oh, good.
Yeah, after 1 to 2 weeks, the morphine doesn't even give you that drowsy effect. You still
Right.
get that bit of euphoria, but
Yes.
you won't have that drowsy effect and you can get on with your life.
Yes.
So that's the myth that I want to get rid of. And as I was saying, morphine also helps with shortness of breath. A lot of people don't know that. It cuts the pathway. So a lot of patients that have lung cancer or any kind of
Mhm.
cancer where the spread is to the lungs, you give morphine, and do you know that even though they are short of breath, they have no clue that they're short of breath,
Get short of breath.
because it cuts the pathway that tells the brain that you're short of breath. So you feel
Ah,
comfortable. And who wants to have shortness of breath? Who wants to feel like if they're drowning and cannot
drowning.
breathe?
Correct.
So morphine is also beautiful because it also does that. So
Yes.
you see, so it has other things that it does do, that it does, and I mean, I say does do. I do a real Trini thing there. Anyway, there are many other things that morphine does, and that is the beauty with it, and that's what I try to push. And when patients finally listen to what I have to say, then they go forward. Because of course, I tell them, I say, and don't let your neighbor, the next
Hmm.
door
Hmm.
neighbor, the auntie, the Google, the whoever
Yes.
tell you otherwise. This is what it is, and we need to stick with the
Stick
program.
with it. And
Yes.
this is
So
why you are the professional to, firstly, you're not just gonna give morphine or whatever other drug you're going to use. You assess the pain levels, and this is what the layman not going to do. They just say, here, this worked for me, take that. No, you
yes,
assess the pain levels, determine what is the smallest possible dose to start effecting a change and increase as necessary, and that has to be done with guidance. And again, it is important for the patient and family to know, and I like that term. First time I was hearing it, that um, opioid naivete. Yeah.
Mm.
So, when you're not accustomed using medications, and you might see that in a lot of older patients. So, guys, if you have somebody who is on morphine and similar type of opioid drugs and they're drowsy, remember, as Doc said, it will only last a week or so. You will have some of these side effects, but it's better that they're drowsy and sleeping in comfort rather than being in pain. And somebody just mentioned, and I just want to highlight it. One of our viewers saying constipation is a big thing and medication does that to you. Can you dive into that a little more with regards to medication in constipation, especially medication you tend to use in palliative care management?
Okay, so any opioid, and let me tell you all, in Trinidad and Tobago, we are the most fabulous country in the world, where the one place that you could just go to the counter and say, "Can I have tramadol, please?" And they'll say, "Sure." How many bottles of tramadol do
So
you
true.
need? All right.
Crazy.
Tramadol is a very weak to moderate opioid, but it's still an opioid. Codeine and
Yeah.
Panadine, Panadine, where everybody just taking left, right, and
Yes.
center, that's an opioid. So why are you afraid to take morphine? If you're busting up Panadine, you're busting up Tuscasad. In fact, Tuscasad, that's the cough syrup that they had to start hiding
Right.
because people were just drinking it down
Yes.
because it has codeine in it, and therefore it's something that will give you that sleepy effect, that nice drowsy effect. So there's tramadol and there's codeine, and then you have things like morphine. So I really don't know why people be afraid with the morphine. Done jamming down the codeine and thing, and they don't understand that that too is an opioid. Now, all opioids will cause constipation. It is the one
Mhm.
side effect of an opioid that you cannot fix.
Yeah.
Drowsiness will pass. The vomiting and the nausea feeling will pass, but that constipation will never pass. So as
Yes.
long as you are on an opioid, you must take something to pass the stool. And how do you do
Mm.
it? You need the gut to move like this, because what an opioid does, it just makes the gut stand still. You
Right.
need that movement of the gut to push the stool along. So you have to use something that is specific to push it along. And that is like Senna. Senna does that.
Mm.
The other drug I like to use is lactulose or Dufelac. They have
Lactose.
different brands to it. And that helps to help propel and push the stool out. If the stool has been hard because you've been sent home with morphine, not by moi, you've been sent home with morphine or some other opioid, and not placed on something that will help with the constipation. Sometimes the stool is compact. So what
Yes.
you'll have to use an enema to start the movement. Because if you have a compact piece of stool, sometimes I can manually evacuate it. Yes, I do
Mhm.
things like that. But
Yes.
sometimes you can fleet olive oil, like you warm the olive oil, you put it in the fleet bottle and you push it in. It coats the stool, and then you push in the fleet after, the contents of
Mm.
the fleet after, and you get a nice movement. And then from the next day, you can start using the senna or the lactulose. Yeah.
That is, you said something there, and that process, because sometimes people use the fleet, but you don't prepare, so that you is it that we compact even more
Meaning what? Tell me what you mean.
the order, because you said you do the fleet after your like the fleet olive oil
Oh,
after.
it's the olive oil is just to coat it, because remember,
Right.
if you have just had stool there, you have to push it out, huh? So at
Yes.
least the olive oil will grease it a little bit so that it could push out a
Right.
little easier, because at the end of the day you still might have to push it, eh? Do a little push to help it move forward.
Right.
And I find by doing, I stole that actually from a gastroenterologist. He was talking about it. I say, hey, yeah, I taken that idea. So but using it, and it works really, really well. Putting the
Hmm.
olive oil first and then
Right.
using the fleet content, and then it comes out a lot smoother. If
I,
it
I'm glad
doesn't,
I mentioned the Senate, yeah? The
mhm,
Senate, because we are a population who like bush, and
yeah,
everybody has some kind of Senate pot somewhere, or some neighbor has.
yeah, so you could use that, but be careful. I don't overdo it. Like one
Yes.
time, I gave my granny what you call this thing, sour sop leaf. A
Yes.
boiled soursop leaf, the woman sleep for like nearly 24 hours. don't don't go boiling 20 senna leaf, all right?
I love it.
Just do it like a little leaf at a time and see which how much you need, and kind of experiment until you get the right concoction, all
Yes.
right? Don't go and boil 20, and then when the patient in severe pain because it cramped in their
Then
stomach, you come and blame Dr. Watson, all
what's
right? Plus, you can get senna from Nature's Way. They have a
right?
senna in a tablet form, and you can take that as well. And I've seen certain pharmacies actually selling the dried leaves in
Right.
packets
Yes.
using for it. Yes. Now,
So
the
thanks, Sherry, and for that constipation question, because I know it's something that bothers a lot of patients. Doc, remember what you're going to say, yeah? But it just crossed my mind because you mentioned that the opioid drugs cause they almost paralyze basically the entire system, so that you
mhm,
need something for the system to be able to push out
yeah.
the stool. Is this why people say, but I'm drinking a lot of water, but it's not doing very much for those who are using opioids for an extended period of time because it needs something else to
Yes.
cause a movement?
Some you see when you trained in using different medications, have to train in each aspect of it, including the fact that it will cause constipation. So a lot of people are sent home with things like paraffin oil,
Right.
or they are told to eat more fiber, drink more
Yeah.
water, or use things like Benny fiber and those sorts of things. Understand that if your gut is not moving and I given you a set of fiber, what do you think it will do? It will just bulk up inside of
That's
there and
right.
it will not push out. So nothing wrong with using the paraffin oil, but you must use it alongside something that will actually push the stool out.
Yes.
Dulcolax is not my choice because Dulcolax is really even though it's the worst tablet on earth, I've never tried it again. I'll never use it again. It's really a stool softener.
Ah.
It's not really made for the pushing out. Now, the
Yes.
reason I give you the additional things like the senna, there's even one called Overlax that you can put under the tongue. The reason I use other methods other than the lactulose is very sweet, and
Yes.
patients that are dying don't want to drink no sweet taste and
Yes.
kind of thing. It sometimes upsets them. So that's why we must have other
Right.
ways of introducing the same sort of drugs for the constipation. Yeah.
Wow, that's fantastic. And those little tidbits, sometimes I remember when my father was close to passing, and it just dawned on me, he liked apple juice or pineapple
Mhm.
juice, and he just couldn't stomach it. And I said, Daddy, you need to drink. And I'm like, I'm giving you what you like. And I'm now thinking maybe it was because of that sweetness, that he just couldn't tolerate it anymore.
Sometimes it could be that. It also could mean that if your father was passing, and I always tell patients this, just naturally, and that's why I liked how you brought up that about death and the taboo behind that, behind talking about death. Death is inevitable. So there is life. When you have a person that's born, you have all these celebrations. As soon as the baby comes out, the baby cries. And what's the first thing the baby starts looking for? It starts looking for milk. It's an
Yes.
instinct. The
Yes.
same way your body has that instinct to live, it knows exactly how to die. And
Wow.
a big part of it is when you see your family member moving away from food,
Yes.
because food is for life, food is sustenance for life. And if the body is breaking down and shutting down, one thing it does not want is food. So that's why
Wow.
I tell people, understand the body knows how to die. When you see a family going through different steps, like stop eating, withdrawing themselves from like the crowd, they don't want to be in with
Hmm.
family members, they want to be alone, they curl up and they stare in a corner of the room, things like that, then you know that death is near. So that's possible. Stacy, what happened with your dad?
Wow. That you said something that's so profound, and we take these things for granted, and sometimes people see us as persons in medicine, and but you said something that went beyond medicine. And I just want to, I'm not going to quote you directly, but you said, when we're born, we look for milk. We're looking for things to sustain us, to give us life. But yet, when that time comes, our bodies know how to die, and it responds differently.
Yes, it
We
does.
wow, that is my goosebumps raised. That is profound. And
Yeah, and
yes,
once you know
one
that,
question said, Shavana, I'm gonna show it. Shavana is so true. Shavana Katik always looks on, and she said, "This is deep. It is. It is because sometimes we're holding on, because there are loved ones, and their bodies are showing us. And listen, we going on. You don't have much time remaining,
yes,
so we have to be a little more in tune. And you mentioned some things there, they want to stay away from the crowds, they do withdrawing from food, and staring at a corner, and all of these things are some indications of somebody passing. And I want to speak a little bit about how you manage and how you have these conversations, these difficult conversations with families regarding that process, because everybody knows you to be, down to earth and giving real life info. How is that for you from a personal level? How are you able to manage something like that? Because it's something you will face regularly. How are you able to come home and see to your family and see to yourself when you have to support patients in this way and see them throughout this passage?
a lot of people ask me that. Let me just say, when you're about to specialize, or when you're about to go and do something, just how you wanted to specialize to such an extent with you that now you have your PhD, um, it must be something that you feel in your heart.
Yes.
So I was forced to go. I could say it now that I'm working in Petrotrin normal. I was forced to go to a conference about palliative care.
We'll talk about more of that offline.
Yeah, I was vexed. I was like, what the jail is this all about? Palliative. I can't even pronounce it. I say, what is this all about? So I go on to this conference, and for years I was struggling with. I want to specialize in. I want to be in family medicine, but I want to extend my knowledge into something else. And after I did that 2 day seminar, there was nothing inside of me that said that. Every bit of me was going, that's what you need to do.
Yes.
And I don't know why. It's the strangest feeling I ever had, where I was like, that is what I'm going to do. And then I heard there was a master's program. I jumped at that. And I am just able to do it. I am
Yes.
not saying it is not hard. I get very attached to people sometimes.
Yes.
Sometimes I do cry a bit, quite
Mhm.
a bit when they pass. I
Hmm.
tend to limit how much funerals I go to.
Yes.
I barely go to funerals because then I'll be going to a funeral every week, and that takes out a lot of me because
Yes.
it's not so much the funeral as watching everybody cry and
Yes.
feel sad, and it gets to me. So I don't do that. I don't like to go to funerals. Sometimes I do have close friends and family members that ask me to take care of their family, and I do have to go to those funerals, and I always end up in a tailspin of emotion and crying, etc. I try not to bring it home. I try to leave it at the door, but sometimes it's not so easy because sometimes I have to deal with young mothers. That's the worst for me, when you have to see a 32-year-old die and she has this little 2-year-old running around and wanting to hug her, and she's unable to do things
Hmm.
like that. I had a 7-year-old. I think that was the worst one. My husband took me because it was quite down in Cedros, and I know where I was going because I was be all over the place. But Cedros, usually I'm very independent. I say, you better come and just drive with me. As when I saw the child, when I come in the car, my husband was crying. He even seen the
Hmm.
child, and just the
Wow.
thought of it. And then when he saw the parents come out holding the child, it was a very emotional kind of thing. So
Yes.
I don't like to do little ones. I don't like to you do young mothers and young fathers and
Yeah.
young adults, but I have to do it. And um, I just learned to deal with it. I would say just learn to deal with it in my own way.
Wow.
Yeah.
So, Somebody
must
just says,
be.
blessings to you both. I want to show thanks, Shuma, for that. But today in this show, we will send blessings to Dr. Watson. Sometimes we forget to pray for those who care for us and pray for their well-being and peace of mind. And whatever God you believe in or whatever good vibes you believe in, send it her way. Because it's not easy. Each of us have experienced pain in some way, and we know how we feel. And she is taking up the pain of others each day. So, Dr. Watson, thank you so much for that. Somebody is just saying on Avalon, Avalon, I'm seeing you here. Thanks for logging in. And Avalon is saying a special thank you for such valuable information. And somebody on the YouTube, on my YouTube channel says Tanisha wants to know if she's getting a gold star for her explanation on palliative care. So we're seeing it here. So palliative care involves management of the patient more closely by ensuring caretakers and others who assist with the patient's needs follow your recommendations.
Yes, that's a big part of it, because the as I was saying before, when you go to these homes, the caregivers are in complete disarray. They don't know what's going on. Why is she not eating? Why is she not sleeping? Why is she agitated? Why this happening? And when I finish having the conversation with them, they feel so relaxed.
Yes.
And then I tell them, you're doing such a good job,
Good
because
job.
half of them don't think they're doing a good job when really they are.
Yes.
All right. So yeah, that's all part of being a palliative care doctor.
Thanks, Shavana, for your comments. You're amazing, doc. Can't imagine having to console patients day after day. Yeah, but that's part of the job. Part of the
Yeah,
job when
part
it
of the
reaches to
job.
that point. Yeah.
It, it,
So,
it,
sorry, doc. Go ahead.
I was just going to say, if you're doing this job, it has to be something that you're really passionate about.
Yes.
Palliative care, I'm very passionate about it. And I think that's how I get through it every day.
Yes.
Yeah.
Somebody just sent a message on my other Facebook platform. So I'm juggling here.
Yeah.
They asked about the use of CBD oil
Mm-hmm.
and
Okay.
derivatives. What can you share with us?
Okay, so let's talk a little bit more than CBD. Let's talk about the real CBD.
Yes.
Now, CBD oil that you get in Trinidad and Tobago is legal because it doesn't have THC. THC has to be over 3% for it to be real, what we class
Right.
as CBD oil. What you get down here is like a 0.003 something on it. And it's not what I would use for pain control
Right.
or pain management. However, some people use it and it does wonders, where the rest of people use it and they say, well, this thing don't work.
Yes.
Now, because we are palliative care trained, we also trained in the use of marijuana. And it's such a good drug because we naturally have receptors in our bodies that actually the marijuana goes directly to those receptors. And we do have
Right.
those, and we were born with them. The issue at hand, why marijuana is so frowned upon, is because our receptors don't mature properly until we're 25. Yet you have a bunch of 14 and 15-year-olds walking around
Wow.
smoking weed. And when you do that, it mushes your brain and you
Mm-hmm.
go nowhere in life. But if you are using it after the age of 25,
Right.
then at that point, your receptors are fully mature and you can handle it without getting the damage that it causes when you do it
Right.
before. So before that age. So I would use it if I
Wow.
was legally able to use it. I would use it because marijuana does wonders for pain,
Yes.
for appetite, because if anybody ever smoke weed, they must tell you that they get something called the munchies and they want to eat
Yes.
the whole house down. So it helps with appetite for patients that don't want to eat anymore. And it also helps for relaxation and for deep sleep. So yes, and proper CBD oil, like the ones that would have the THC at 3% and above, actually aids with maintenance of sleep.
Ah.
So yeah, and we don't, in palliative care, you don't smoke or vape marijuana. You must eat it or you must inhale it. Like, you put it in a vaporizer, you put a
Right.
towel on your head and you inhale it. There's special vaporizers for patients that are palliative that use it. And so, yeah, if it was legalized, I mean, decriminalize it, they legalize where I could just write on a prescription, hey, Mary, go get this and that. But if it does happen, then it would be something that I be very much will be using quite a
Yeah.
bit. The other thing is patients will ask me, so if you're under 25 and you have to use it now, if you are dying and you're under 25, I will use it.
Yes.
But if you're under 25 and you are in remission, I'm not going to be using it.
Understood.
If you understand that. It's
Yeah.
only if you're under
Understood.
25 and you actually you're in hospice, meaning that you have weeks to months of life, I will
Yes.
be using it patients like that. Yeah. So we have to be still very responsible. And for those out there who have any friend or family that doing this thing before the age of 25, they better stop. Otherwise, they're going to end up in with a mushy brain and
That's right.
excel not. All right. Good.
So we get in real life tips here, and not just about palliative care. And there are reasons, there are scientific reasons as to why prior to the age of 25 we are supposed to be smoking the herb. So cease and desist. All right,
Yes.
you want to be
Cease and
functional
desist.
members of society. Save your
Yes.
brain. All right. If you have to wait until after 25, and then
Yes.
quite often the fantasy wears off in many.
Yeah, by the time you turn 25, you're not going to experiment with that. No way. It's very, very unlikely. You'll be like, oh, I'm now 25. Let me go and have some marijuana today. No,
Today.
that doesn't happen.
Correct. Something you mentioned though, you said that if at being administered, you usually have the patient eat or use the this
Vaporizer.
vaporizer.
Yes.
Why is that? What is the
Once you put flame to something, like light it or
yes,
inhale something into the lung other than oxygen, it's not good for you. It will cause damage.
yes,
So whatever you, even if you're giving this person marijuana for sleep, so like in Canada, they have actual sleep clinics.
yes,
And I'm very sure that you see patients all the time, Stacy, that tell you the one thing we don't do is a lot of people is sleep. A lot of people
correct.
suffer from severe anxiety,
Yeah,
especially since COVID, etc.
yeah.
So it does help to aid in sleep, etc. What I was talking about before to even lead to that? What you asked me?
No, we're talking about the use when you put
Oh,
flame.
wait,
Yes,
same, right. So when you are actually, you see my brain? When you are actually using the marijuana, it must be edible or vaporized so that it doesn't damage your lungs. I
yes,
can't safely say give you something that could end up causing you to get lung cancer, bronchitis, emphysema,
correct.
and with this vape thing now, what they call it popcorn lung and all of these different
Yes,
things. I cannot risk things like that. So it must be given in a safe manner
yes.
over 25,
Over
unless
25,
you're dying.
unless you die.
Yes.
Somebody mentioned as well, and you may be aware of it, CB1 or CB2. Do you know what that is? That person on is live. Can you give us a little more information? I'm looking at. I'm not sure if there's a difference with the oils, maybe. And they're
Let me
asking.
I'm looking at my thing in the CBD one on two.
Yeah, yeah, one or two. I'm not sure. We're trying to find out for you while we're on, and if not, if you could give us a little more detail as to what you're referring to. Let me just put up another.
I'm not too sure how we do it. It's you have CBD to THC levels. So you
Right.
can have a CBD that ranges in a certain amount, like a ratio. Let's say
Yes.
CBD 10 and 10 to 1 or 10 to 2
Two.
of the amount of THC that is in that
Right.
particular oil. Because remember, when you're doing these things, you're not just buying marijuana off the road,
Yeah.
etc.
Correct.
Usually the oils are made knowing, because this is how you'll do it. You're going to actually use oils to actually vaporize or to ingest, where they
Right.
want to use it in brownie, sweetie, whatever you want to do.
Yes.
But when you're making the oils, especially in Canada, where you have medicinal marijuana in the
Yes.
form of oils, they actually have ratios, and
Mm,
they change the ratios depending on how well it works for someone versus somebody else. So
else.
if this particular ratio is not working, they will change it or they'll increase it. So
Understood.
I don't know if that's what they mean. I don't
Yeah.
know.
And they haven't sent another message. So I'm hoping we've answered. And remember, guys, this is your opportunity. We only have a few moments remaining. So if you have any questions, now is the time. But Doc, we spoke about, for example, the use of the opioids, the morphine and the like. We've touched on the CBD. Um, are there any complementary therapies that you would prescribe or recommend for pain management? For example, massage or meditation. Can you
Of
go into some of
course. I
that?
mean, it's let me tell you how it works. Stacey, it's supposed to have it's supposed to be multidisciplinary, meaning I'm supposed to have a full team surrounding me. I don't have that. Is
Yes.
kind of like is me, right?
Yeah.
And sometimes I have to fight that, yeah, you need me in this particular situation. But in our unit, you're supposed to have nurses, other doctors, anesthetists, oncologists, physiotherapists, such as yourself.
Yes. Yes.
There are other ways that you can make a patient comfortable, like massaging. That is not physio, by the way. People just mix up the two things.
Thank you so kindly.
Yes, massage therapy is just anybody could come. You can have a person that's actually trained in massage therapy, or as a caregiver, just do some nice soft touches, squeeze it. I had this particular patient, he had a very big mass in his neck.
Mm,
And the only thing that would soothe him was rubbing the head and rubbing the neck. And his daughter used
right.
to do that all the time, and that soothed him. So yes, art therapy, music therapy, all kind of thing is involved in palliative care, including looking good. One time I had a patient dying. I mean,
Yes.
she's dying, and I asked her, "What would you like me to do?" And she said, "I want a haircut and nail polish. Look at he, that's the husband. Look at he, groom up and looking good, and look at me." So I tell this patient, I tell the husband, I say, "Let me tell you, I don't care what you do. You need to find somebody that'll come here and cut your hair and do your nails." And he did. And she was the happiest person. And she died
Yes.
like a few days after that, but she died looking like a beautiful beauty that she wanted to look like.
Yes.
So all of that is part of the multidisciplinary team. So yes, you do play a big role in it, Stacey. It's just that because we don't have, because as I say, it's a new thing, it's a rare thing. It's only about 5 a week. We don't have the team put around us.
Yes. Correct.
But if we did in a
Yeah.
first world country, they would have that kind of team. Look at The Resident. You ever watch that show?
Oh, I love it. Oh my God.
Right. You see how they push palliative care in
Palliative
hospital
care. Oh yes.
now becoming a big thing. And they say by 2060, I could be done going by then, but by 2060, we will be the most sought out doctors in the world.
Wow. Yeah.
Yeah.
And I could see that because our populations are aging.
Hmm.
So that you're looking at all the things that come with aging. You know, we everybody wants to live long, but we have to remember all the things that come with it. And for sure, the older we are, the closer to death that we will become, and the more illnesses and injuries we may sustain. So I could see that for sure, for sure, for sure. Oh gosh, you told me The Resident, and I cried at the end, but that's another conversation for another day. This this listener, this person who's online, it's not a palliative related question, but I think I'm gonna shoot it to you, Doc, because we're now in flu season and all sorts of flus. So this might be of quick interest to everybody. Is it safe to do steaming with peppermint oil to help when someone has the flu?
Why
Um,
not? Why not? As long as it doesn't irritate. Some people are very sensitive and get irritated with oil baths and things like that. But most of the time, it works really well. And another thing somebody told me once, they said, boil hot water, put it in your mop bucket, and throw some oil bath or peppermint oil in it, and mop your floor and put the fan
right.
on and close it. And when you enter, you know, a whole room of Vicks. My father would absolutely love it. He's addicted to Vicks. Every time he passes the Vicks, it going up, he knows. Right? So
Oh,
a lot of people in Trinidad love Vicks. So another thing that you can do is that if you don't want to just put it in a steamer, you can mop the
yes.
floors, close the doors, have your air conditioner, your fan on, and you get that sort of pepper oil kind of scent, and it does ease the airways.
Yeah.
Yes, so yes, you can use it.
Thanks for that question, Steffi. Thanks, Doc, for answering that. So I just want to start tie us down. I've kept you for longer than I thought, and we have so many people on. We have on this platform over 20 something people. We have over 20 some people on another. We have people on YouTube. And guys, this will be here. I will share it on my pages so you have it after to share with your friends and family about this area of care. And I want to ask you, what do you think is the biggest challenge in making palliative care accessible to everyone who needs it in Trinidad and Tobago? That's a multifaceted response.
I think the first big thing that people need to start understanding how important it is once you've
Yes.
been diagnosed with an illness,
Yes.
especially if you are at the end of life, meaning you get diagnosed with something at stage 4. I will give you an example why. If it is that a person gets diagnosed with pancreatic cancer, most of the time it's at end stage because you don't know you have it until your eyes start to turn yellow, unless by some miracle you're doing ultrasound every year or CT scan or something you do and you pick up on this. But most of the time you get it when it's spread. And doctor tells you, okay, now you have to go and do this Whipple surgery, and you go forward and you just do what the doctors and oncologists say oncology and the oncology unit says. But if it is that you have a palliative doctor there, they can give you the options. They can tell you with a Whipple's procedure, which is what you do for pancreatic cancer, the it's a very dangerous procedure, meaning that it has a high risk of death. You end up in ICU. The recovery is very long.
Yes.
With pancreatic cancer, once we find it at 4th stage, you might have 6 months to live. Do you want to live 3 of those recovering from a surgery that you'll eventually die from? Right? So these are the kinds of things that are important. People need to understand the importance of a palliative care doctor for people to start demanding our care even when they
Yes.
get diagnosed. They're supposed to be able to say, I would like to see a palliative care doctor just to get a second opinion. And that's why I'm doing things like this. So thanks
Yes.
for having me on here today, Stacy. So that's why I'm trying to do my top tips and go all over the place talking about palliative care. On top of it, note that we are very rare. We only have like about everyone, the most qualified ones, the ones that have most experience. I think it's about 5 of us in the country at this point in time. We may have more junior ones, but I know it's 5 for sure that have the most experience. So it's rare. It's not something you find. But believe it or not, Stacy, I am opening up a small little company. I hope you don't mind me saying that.
No, of course not.
With nurses and nurses, I'm only now starting the interviews. And part of it is educating them and teaching them about palliative care, because we do need more nurses and nurse aides to understand it. So it will be also continuous learning and training in this very specialized field, because I can't do it all. If you ask my family, sometimes I'm very burnt out. I work all the time because I've been all over Trinidad and Tobago by myself sometimes. So I need help. And that's why we decided to do this. So when these nurses and nurses go to your home, they'll be under my supervision and they will be trained under me and Mike. And so, I will not put anybody in your home that I don't completely trust. And it's not under my care. Yes.
And this is Elena. I don't know if you remember Elena, Doc. You may remember, she's passed through Petrotrin.
Okay.
Elena is one of the best nurses that I know, and I'm happy that she's here and endorsing what you're saying. We need to educate our population, and this is why we're here to help in that process of educating. Is there anything on the horizon in palliative care, any innovation? We talk about AI. Innovation is not just about AI. Any innovation in palliative care that you're excited about? Anything that has that you're seeing popping up in the research, and or maybe something that you would like to see here that will be new and that will assist you in providing the care that you do?
If I tell you what it is, you're going to laugh. But let me tell you what it is. What excites me more than anything else is something called a Macy catheter. This is something that we're trying to get because it's FDA approved, right? You need to be FDA approved. And right now we're doing trials with this Macy catheter. Now, what this Macy catheter is, we put this catheter in the rectum of the patient and we can deliver pain medication and fluids, not food, but
Right.
fluids to the patient. So let's say the other day I used it on a patient. This patient could not swallow. She was in severe pain. She couldn't even, so you can't give the morphine. Even if you do
Right.
give morphine to a dying patient orally, it stays in its stomach because remember, everything's shutting down. You think your stomach digesting food. Even if you force food with an NG tube, that's why I don't believe in NG tube. If you put an NG tube and you pump in food in somebody's stomach that's dying, it's not going to give them nutrition. You are just, food is just sticking inside the stomach and going
Inside
nowhere and
it.
making it more comfortable. So this Macy catheter now, because your cells in your rectum absorb like whoosh. So as soon as you put morphine in there, oral morphine, and you could crush,
Wow.
it comes with a crush system as well. So if you have pills, you can crush these pills and put it and administer. And in no time, within 5 to 10, 15 minutes, patient has full on morphine, full on meds, everything without having to harass them to swallow anything, including giving them Pedialyte and water. And you
Right.
could leave the mouth for mouth care. Vaseline, glycerine in the mouth, ice chips to make the mouth feel less dry. No one wants a dry mouth. So that's what I'm most excited about, Stacy. That's what I say. See the things that I get
I
excited
mean,
about.
can you imagine? Only a doctor could be excited about a catheter. That was the last thing I was looking for.
Yeah. But yeah, that's the kind of things we want introduced into Trinidad and Tobago so we could give ease the family. The
Yes.
patient could be
Correct.
sleeping and you don't have to wake them up to say, hey, your morphine due. You just put it in the catheter, the person sleeping and you get the morphine.
So
And
what do you
patient
think
gets
is what do you think it's gonna take to get that though?
well,
That seems
we've
as
been
simple as it is. It sounds like a game changer though.
we've asked certain hospitals to come on board, and some of them have said yes. And
Great.
in San Fernando, unfortunately, only the two private doctors here that do palliative, that's me and Dr. Stacy Chamley, have been trying to use it, and I use it quite a bit. Yeah,
Right.
but this is just the trials. It's not like we
Yes.
have it. Like we
Understood.
have limited supply. I go and I beg for it, and I get it from a colleague of mine in Port of Spain, and we trial it on patients. And the when we use it, family members say, "Oh my God, this was the best thing ever in the whole wide world." So
Yeah.
that I'm excited if this comes onto into the hospitals and
Hospitals.
hospitals can use it for all their
Yeah.
patients that don't have the ability to eat and drink and get proper pain meds, who want to get stick up every minute with for
Correct.
morphine and get joke up and things like that. Nobody wants that. So this is a pain-free, easy way for patients to do it. The only patients that can't use it are patients that have colon cancer. I mean
Right.
rectal cancer, where the
Rectal.
cancer is actually in the area where we're trying to insert the catheter.
Certain.
Yeah,
Understood. I don't know if this person looks familiar to you.
that's my mother.
Hi,
Thanks,
Mom.
Mom.
Thanks for
Thanks, Mom.
joining us. And this is what support is. I mean, um, Dr. Watson's family is always there to support in any form or fashion. Her sister, mom, dad, daughters, her husband is really a lovely team that she has that gives her permission to do the work that she's doing. And
Yes,
just by
yeah.
the way, somebody asked earlier on if you're French. I don't know.
I was born in France.
L-
That's as
I
far as
didn't
I go.
know
I
that.
lived there for about 3 years of my life. I probably used to speak. My father and mother speak French fluently.
Mon
Um,
Dieu.
yeah, so yes, I am French, my darlings. Yes.
Right. And this is very, very cool. So we need to have another talk. So I hope that listener is still on. Yes, guys, she's French. I wonder why. I'll tell you who. Anton Akau. That's the person who asked the question. So maybe might be some relative or
That's my
something in the
husband.
wind.
That's my husband asking
Oh
foolishness.
my God! I love it. He's sharing your business.
Yeah, he's sharing the business. He wants to make me look, woohoo, I'm fancy. I'm French.
I love She's fancy. I love it. I love it. So, guys, we are at that point where we're ready to say goodbye to Dr. Watson just for tonight. I think that we're going to have her again once she's willing on another topic, another area of her expertise, because her expertise is vast. And maybe just talk about some of her top tips, her top 10 top tips that we could
Yes,
share. Maybe we could do that
of
here.
course.
So I want Doc, just tell the people where they can follow you, and
All
if
right.
somebody
So,
is actually asking about information with regards to nurses, they may be interested in applying. So if you can give us some more info.
okay, so I think at the bottom of the screen you had
Yes.
the 319-8955. That's our personal phone number for the office, and WhatsApp. You can send your CV there, or to the Dr. Nadya Watson gmail.com. You can send your CV with a certificate of character, and we siphon in through all because we had such an overwhelming response. It was like a thousand of
Wow.
CVs. And I'm not exaggerating. So it was a lot. I am on Facebook. That's my biggest following, the Healthy Living Medical Practice. I am also on Instagram as Living Healthy Living. Let me see what on Instagram. I don't even know now. If I could
That's when you
take
have
a,
it. You're doing so much work on it. You just
I
I do
even know
all
what
the
I
time.
call myself on Healthy Living. Hold on, let me see. All right. So I am under the Healthy Living Med on Instagram, Healthy Living Med, and I'm also on TikTok as at Dr. Nadya Watson. So that's the acting, this
Yes.
A that circle up, Dr. Nadya Watson on TikTok. And I do a whole bunch of top tips, free medical education for women and men. And we also do a live every single Saturday. So if you want to come on between 9 and 10, we do a live. And in that live, you can ask me anything and you get
Anything.
free advice.
That's what we're
Yeah.
talking about. Again,
Yes.
we, doctors like medical practitioners like Dr. Watson. It's not that we want to see everybody in our offices. We want to improve your health and wellness. Um, and we do that by doing, having platforms like these and sharing information to try to prevent you from reaching to us where possible. And for you, the viewer, to take control of your health. You are the most important player when we're looking at health. So, Dr. Watson, thank you so very much for joining us.
Thanks
I
for
am so
having me
happy
again.
that you have blessed this forum, blessed this stage, and we will be together again here, and we will gonna keep following you on all your social media platforms. Guys, the information is here. I will post it on my page. Someone is asking if it's permanent or part-time employment. I guess it may be a combination depending on how things
Yes,
pan out.
it will depend on how many. Remember, now we have many house visits we go to.
Yes,
It's now for the person to ask me, which is a common thing. Do you
yes,
have a nurse or nurse aide? If it is that they want someone long term, then it will be long term. Let's say it's an Alzheimer's patient, but may also be a hospice patient where it may be weeks to months, and then the patient will pass, and then hopefully we may have other homes for you to enter into to help, especially guided under my guidance and trained under me. Yeah.
Thanks, Steffi, for the question. Elena, yes, I know you love coming to my office. You could still visit, but without us having to treat you, right? Doc, I'm giving you one last opportunity just to, tell us your top tip regarding palliative care that you want the viewers to cement in their minds.
Okay, so today's top tip is to understand what palliative care is all about. If it is that you don't really understand properly, note that I am a master at pain relief. I am a master at getting caretakers to understand how to take care of you the right way. All right. So if it's anything that you're here today, those are the two big things. I am also very good at introducing the fact that death may be near, something that a lot of doctors do not know how to do. And I'm very efficient in terms of trying to teach you how to do advanced care directives and end of life care for those of you that have terminal illnesses. It doesn't matter what stage, it is that you should all, in fact, all we need to have an advanced care directive and an
Yes.
end of life care plan, because you never know what's going to happen tomorrow. That's the one thing I've learned in palliative care.
Yes.
Life is very short.
Thank you so much for that top tip. And Doc, don't go anywhere. Just hold on a bit. Let me just have one last word with the viewers.
Okay.
Guys, thank you so much for coming on to our first session for 2025. And we have so much more in store for you during the year. If there's any particular area that you would like me to get one of our experts in to have a chat, just drop me a line. You know that we would try to facilitate all your requests. If you have any questions regarding palliative care, drop a line as well, and Dr. Watson will be willing to respond to you. Remember, all her information, I will post it up on my pages. So for those of you who are interested in joining her company to provide nursing care at varying levels, if you're willing to volunteer as well, Elena is one such nurse who said she's willing to volunteer. Just feel free to contact her and be part of this movement, because this is something that all of us may require at some point in time. And remember, palliative care begins from diagnosis with a serious illness straight until the journey at the end. And again, thank you all for tuning in. Feel free to like Back in Motion TT on Facebook, Instagram, TikTok, and YouTube so that you can stay in the know with information to improve your health and your wellness. See you soon, guys. Take care.